put this up on YouTube, but it'll be behind a wall, sort of. So, good evening. I'd like to welcome you to our class on healthcare innovation. Tonight we have a very special guest, AJ Holmgren, a graduate of Harvard's Business School and one of the foremost authorities on metadata and log data and how it can improve organizational management. Thank you so much for coming, AJ. Please take over.
Well, thank you so much for having me. So I'm going to give a little bit of an overview of, as Eric just mentioned, EHR audit log data, which I think is a fascinating topic. It's a really emerging and nascent field of study, both for researchers as well as for folks working in the operational side and the clinical side of healthcare delivery organizations right now. For some background on myself, my name is AJ Holmgren. I'm an assistant professor at the UC San Francisco School of Medicine and the Center for Clinical Informatics and Improvement Research. And I have a PhD from Harvard Business School, where I study how physicians and other members of clinical care teams interact with digital tools in order to improve care delivery and become more efficient, productive, and deliver high quality care. So the quick roadmap for today is I'm going to go over a little, what is EHR audit log data or metadata, because I think it's going to be a broadly unfamiliar term to many of us, but I think it's actually pretty intuitive once we see some examples. Then I'm going to go over a few examples of audit log research that really starts to highlight, the transformative potential of being able to use this data and leverage it both for policy purposes as well as for active practitioners, health system leaders, and physicians who want to optimize their own use of the electronic health record and their clinical workflows. And finally, I'm going to present some in-progress work that is sort of our next steps in what we can do with EHR audit log data. Hopefully this will be a sort of interesting presentation to a broad variety of people. And I think, it'll give a pretty good overview, and you'll come out of this with a pretty good set of ideas about what EHR audit log data can and can't do and what the current state of the field looks like. So to give a brief overview of what EHR audit log data is. So as you're likely familiar, the HITECH Act of 2009 mandates that electronic health records have audit logs. The essential purpose of this was for security. Who is accessing what medical records is an important HIPAA-related convention, and we need to know. The example that I give is that for a while, I had some friends who worked at the University of Chicago's health system. And every time a certain former president who had a residence on the south side of Chicago and got his medical care from the University of Chicago, there was at least one person who got in serious trouble, also known as fired, for looking at the president's medical records. So that's the fundamental purpose of this, is this was a security tool. We want to know who's accessing different things, and we want to be able to apply the law and apply the sort of regulations that HIPAA requires evenly. There have also been some use cases for operations or quality improvement, but in general, the purpose of this was security. This is a tool in order to make sure we are compliant with HIPAA regulations. However, the EHR increasingly plays a central role in care delivery and the work of medicine. After 2008, acute care hospitals and primary care physician offices really rapidly adopted electronic health records to the point where they're essentially ubiquitous today. Almost no one is charting on paper, and almost every interaction a physician has with a patient is documented somewhere in the electronic health record. They are the tools by which we place orders, write prescriptions, review documentation, prepare for new patients, or message with patients. A ton of work goes through these. That means tracking activity in the EHR is a really intuitive and useful way to measure clinician behavior. And this goes beyond just what are they doing in terms of documenting an electronic health record. We can look at things like, what are they ordering for patients? Does a clinician practicing virtually via Zoom in a telemedicine appointment order things differently than how they do in an in-person visit? We can measure all sorts of aspects of clinician behavior, how we deliver care, how team workflows are going when we have these detailed EHR audit log metadata. They measure a whole bunch of different things. Some of the basics are how much time is spent in the electronic health record per day or per visit across functions. So how much time is spent documenting compared to clinical review where they're doing chart reviews. How much time is spent messaging back and forth with patients, and how that varies across different clinicians or different roles. What does it look like for a nurse practitioner compared to a physician, or a primary care doc compared to a surgeon? We also can think about how clinicians interact with the EHR. How do they document? Do they copy and paste a whole bunch of old text? Do they manually write things in, or do they use productivity tools like templated text? How do they message with patients? Do they message back and forth frequently, or do they try to convert everything into visits so they can get face-to-face time? And how many things do we see where physicians correct themselves? Retract and reorders are relatively common. We want to know how often that a clinician inputs the wrong order the first time so that we can build choice architecture that encourages them to do the right thing the first time instead, and potentially cut down on adverse effects like ordering the wrong medication. We can also see how team structures play out in real time, because we can see how different members of the care team interact with and consume information in, or place information in, the same patient's medical records. So you can see over a 6-hour period of an inpatient hospitalization, how many nurses, physicians, medical assistants touch that patient just to their digital footprint in the EHR audit log. To give you a small sense of what an actual audit log looks like in its raw data, this study by Adam Rule and some colleagues that came out in 2020 in the Journal of the American Medical Informatics Association gives a little bit of an example. So essentially, these are timestamps where you can see the exact time, the exact user, the patient record they're doing, and what action they completed, as well as what workstation they completed it at. So we can see when a note is edited or signed. We can see when a doctor views the problem list or looks at a previous note. We can see what user is doing it, what time they did it, and what patient for. Now, obviously, since these are essentially, byproducts of a security task, the data is really not meant for research. Raw EHR audit log data, if you're thinking that was 5 lines, consider UCSF has 900 physicians. We see hundreds of patients every day. They are huge, they're unwieldy, and they're massively complex. So for those of you who are interested in building technical skills and potentially doing something like that after, there is always a market for skilled analysts who can work with audit log data. But the point being is that they're very difficult to use. And this is one of the things that's been a big barrier so far in sort of using these at scale for either operational or research purposes. Luckily, most EHR vendors have started to build varying degrees of polished audit log tools. These range from very bespoke. Clarity is the epic version of this that lets you get at truly the raw audit logs and sort of write essentially SQL or relational database queries to do whatever you want, up to user access log, into a very prepackaged usable system. In Epic, this is called Signal. In Cerner, this is called Lights On. Those are the 2 largest EHR vendors and the 2 with the most mature products sort of measure these. Both of these are really meant for operational purposes, to allow physicians to compare themselves to their peers and say, oh, I spend a lot of time in the electronic health record compared to other primary care docs in my organization or nationally. But they also have a huge utility for operations and research as well. So while their front end is mostly a graphical user interface designed to let physicians benchmark themselves and their use patterns, there's a whole lot they can tell us from back end. So first is, why is this important? Why do we do research on electronic health records? Why do we care about physician EHR use or other clinicians' EHR use? And I think if you're broadly familiar at all with sort of the healthcare workforce, you know that physician burnout and a sort of crisis around electronic health record burden is becoming really real. And it's become even more acute following the onset of the COVID pandemic, where we had a sort of natural increase in demand for physicians, as well as a sort of wave of retirements, especially among primary care docs. So at the same time, we have a lot of physicians who are feeling extremely crunched, as well as what we think of as a documentation burden crisis. We have physicians who are spending so much of their time, nearly half of their time by some studies, on what we call desktop medicine, just clicking, entering data on the computer, all sorts of these tasks that physicians really hate. They really want to spend their time face to face. And so these are just a couple of articles pulled out here that sort of highlight there is a huge prevalence of burnout, low well-being, and issues around primary care workforce. This is especially important given that we have a physician shortage in this country. The National Center for Healthcare Workforce estimates that by 2030, we will be short around 26,000 primary care physicians. So we're in a current situation where we're burning out our existing physician workforce and increasingly relying on them to cover for the lack of supply. So finding new ways to be efficient, increase productivity, and reduce burnout for our clinical workforce is extremely important. There's been a big increase in EHR audit log research over the past few years. This is from a recent systematic review that says, starting in 2019, we went from 2 or 3 papers a year up to almost 60 in 2021. So the upside is there is a significant interest here. We're sort of right at the peak or a crest of the first wave of EHR audit log research. And so I think this is a really interesting, innovative field that's starting to get some real attention. So one of the things I wanted to talk about a little bit first is sort of what have we learned already from EHR audit logs that we probably could not have done previously because we simply couldn't do the type of observational time and motion studies at scale. So here's a 2021 study looking at national data from Epic Systems. And the focus of this paper was really who is spending that time in the electronic health record, who spends time by specialty. And we can see that surgeons spend the least amount of time and receive the fewest messages in their inbox. Then medical specialists, then finally primary care physicians really face the highest EHR burden. They're the docs who have to spend the most time documenting. They get by far the most messages from patients, from other care team members. They're really quarterbacking and managing a lot of care, especially considering primary care is one of the specialties we have the biggest shortage in. It's really concerning how much EHR burden they face relative to their peers in the medical or surgical subspecialties. Another paper, and I'm biased because I wrote this one, is out in JAMA Internal Medicine, where we looked at what does EHR time look like in the United States compared to our sort of peer health systems in Western Europe, in the Scandinavian countries, in Israel, and in Australia. And we find that US physicians spend way more time in the EHR relative to their international peers, which is a really interesting insight because they're using the exact same software system developed by the same vendor. So that shows us that sort of socio-technical drivers of work are really a big contributor to the US specific EHR burden. And of course, those come from all sorts of different spaces. But when we talk about the United States health system compared to our contemporaries and many other developed nations, the immediate thing we jump to is billing. And that's an obvious case because in the United States, physicians have to document to all sorts of different insurance companies' preferences about what evidence they need to approve a procedure. And so since for the most part, physicians aren't aware of what insurance you might have, and they certainly don't know for all of their patients at the point of care, they're maximally documenting in order to meet the strictest needs of whatever payer that they're billing for at the time, to the point where we're having wasteful documentation that's not clinically necessary, but is demanding a lot of high value physician time in order so that they can go back and justify when they need a prior authorization for a drug or for a procedure to the payer. So there are a whole bunch of other sort of US specific regulations around quality measurement, improvement, the HITECH Act, potentially malpractice as well. But the point is, US physicians face a specifically high EHR burden relative to physicians in other health systems across the world. This is a paper by myself and Professor Eric Ford here that looked at how do residents learn as they use the electronic health record and what do their EHR use patterns change. And I think we had one really interesting finding from this, which is that residents get more efficient as they go through their clinical training and they spend less time per patient documenting in the electronic health record, and their patients seen per day goes up, they become more productive. But what they don't do is change the proportion of that time they spend after hours. So this is a really interesting finding about medical culture, where we see now that spending about 15% of your EHR time outside of scheduled clinic hours, documenting while you would otherwise be spending time with your family or enjoying personal time, is just part of the job at this point. And it's really hard, even when we're able to improve efficiency and reduce the amount of time that they're spending per patient, that amount of after hours time is really sticky. And if we want to meaningfully address burnout and improve well-being, medical culture is something we're going to have to look at as well in order to sort of try to make sure that that's something that's not really dragging on the physician experience. This is a really fantastic recent study that came out just a few months ago that looked at a specific use case for using EHR audit logs to determine what are the best ways to treat acute ischemic stroke. So in acute ischemic stroke, one of the most important things is getting time to TPA, so time to the first tissue plasminogen activator. I'm not a medical physician, I'm a PhD, so excuse me if I butcher some of the medical terms. But this looked at across 3 different sites, what are sort of the predictors of shortest time to needle in order to have the highest quality care. And they use EHR audit log data to find out that teamwork or having stable teams of physicians, nurse practitioners, and physician assistants, nurses, and medical assistants coming in and having done TPA before is the biggest predictor of a very short door-to-needle time. So from entering the ED to diagnosis to treatment, the best predictor of that are stable teams. And EHR audit logs, that discussion of being able to go in and see who went and accessed each patient's individual records, that lets us do this study, because otherwise trying to do direct observation of stroke patients across 3 different hospitals across an entire state would be nearly impossible. But thanks to this new sort of innovative audit log metadata, we can build these much more robust data sets to say, oh, this is a new insight. This is a new operational finding that says, you know, we should really prioritize stable teams rather than having an MA that just floats and gets plugged into whatever schedule. We should try to find care teams that work together frequently in order to maximize quality of care. We've also started using EHR audit log data to do big policy evaluation. So this is a study that came out in Annals of Internal Medicine last year by Nate Apathy, who's at MedStar, and Dory Cross, who's at the University of Minnesota, where there was a big policy change at the beginning of 2021 that reduced the amount of documentation necessary to build the higher level evaluation and management codes. The goal of this, the stated goal, was to simplify documentation and alleviate some of this electronic health record documentation burden for physicians. Here we use national data from Epic to look at, well, what really happened. First, on the left there, you have the sort of proportion of evaluation and management visits at different levels. And you can see right at that 1st of January, suddenly, it turns out that a bunch of those level 3 visits that we were billing previously are now level 4 visits. So those are now getting reimbursed at a higher rate. On the other hand, we don't see any change in total time in the electronic health record at all. Those lines are totally flat. So what did this policy change actually do? Well, it didn't really accomplish any goals of reducing EHR burden. What it did do is by saying, well, if I don't need to document these things to prove that a level 4 visit is a level 4 visit, I'm going to bill more of those level 4 visits. This is especially driven by a couple of the really high volume medical specialties, dermatology being the biggest one. But we can see here, you know, being able to evaluate the effect of a national policy change and seeing, did this accomplish its stated goals? Probably not. Is it expensive? Yes, because we're seeing a big redistribution of evaluation and management visits from level 3s to level 4 and 5. This is a really useful application so we can see for policymakers what's going on here and maybe what we should do next time. We've also looked at the impact of the COVID-19 pandemic on EHR burden, where we can see, even though there was a reduction in ambulatory volume, there was an increase in time spent per day. And a lot of that time spent per day increase came from patient messages. So on the bottom chart in the top left corner, you can see patient messages indexed pre-pandemic volumes are now at 150% of what they were prior to the pandemic. And they show no indication of reducing. So there's a really big issue here where this is a new stream of work for many clinicians. Prior to the pandemic, lots of physicians received very few messages. The pandemic sort of activated everyone into getting a patient portal account because they had to sign up for one to get a telehealth visit. It also activated a lot of people who now want to see their doctor, but at the time didn't want to risk going in and being in person and risking COVID. So suddenly there's a big awareness growth around the ability that you can just message with your physician. And this has caused a lot of issues because this is sort of work that is primarily uncompensated and is a demand on physician time. So health systems are really struggling with how to handle the current increased level of volume of patient messages. And the way we know this is real are these electronic health record audit log data and studies that have really, comprehensively shown there is a real impact. There is a real increase. This is a huge new work source, and we're going to have to figure out new ways to sort of address it. Some systems have gone with billing for these messages in order to sort of give systems time. Others have tried to sort of invent chat GPT or bots or artificial intelligence. And others have started triaging these messages, having medical assistants, nurse practitioners, and physician assistants handle the majority of the messages. But the point is, this is sort of a new asynchronous care delivery stream, and we're still sort of in the early stages of figuring out how we're going to incorporate this into physician work. Then I wanted to give a little bit of a primer on some ongoing research that we're doing on audit log data. And one of these is a very operational topic, which is how can we use team-based care approaches to sort of facilitate improved efficiency and reduce burnout for our physician workforce. Documentation is the largest part of physician EHR time, writing notes about what happened in a visit. And so one of the more popular interventions here are scribing, having medical scribes who are often medical students or relatively early career people who are gaining valuable experience. They are being paid. And the idea is they take some of that documentation burden off the physician so they can spend more time practicing at the top of their license and seeing patients. Now, there are a lot of studies about scribing, but for the most part, they rely on either sort of awkward proxy measures, like the amount of charts closed within 24 hours, or they only look at throughput, so the number of patients a physician can see, or they're very intensive resource-wise to perform the study. You have to go out there and watch physicians and their scribes and time them by hand with stopwatches. But with EHR audit log data, we can do this at a much bigger scale and say, all right, I want to know how cost-effective are scribes. So I'm a health system leader. If I'm going to invest in a training program for scribes and hire a bunch of these people, am I really going to get the throughput out of it and be able to see enough patients to make it sort of pencil out in a cost-effectiveness way? So we set out to try to figure this out using EHR audit log data for the entire country from Epic Systems about how does team-based documentation support impact physicians and their documentation in terms of time and note lengths. How do physicians then reallocate that time saved after adopting a scribe? And how does the adoption of this sort of team-based model impact other measures of physician EHR use, like time after hours or time on unscheduled days? This is very much big data research. So this is about 7.5 million observations across 300,000 physicians and advanced practice clinicians. So all users of Epic, which is the largest EHR vendor, across about 389 organizations and 22 specialties. This is specifically looking at physicians. And in here, we're looking specifically at how can we identify physicians who newly adopt some sort of team-based documentation support like a scribe. So thanks to the detailed audit log measures, we can measure exactly how much of a given note comes from each user. So I can tell for a specific week how much a physician is writing their own notes relative to how much another person, often a scribe, a medical assistant, or another team member, is contributing to note text. So that's why we say team-based documentation support rather than scribes. And so we measure this with, if a measure is under 100%, we have some form of documentation support. So somebody besides the focal physician is doing some contributions to their medical documentation. We use a difference in differences estimator in this. So the point being, we're sort of exploiting the staggered nature of adoption to estimate a causal effect from observational data, because we can compare a physician who newly adopts a scribe with their EHR audit log data to a physician who looks just like them, but otherwise does not have scribing. So we can tell very precisely without having to run some sort of randomized control trial what the actual effect is. And the effect is big. So we can see a 10% reduction in time spent in notes per week. We can also see an overall 5% reduction in time spent in the EHR in general per week. We don't see any changes in the amount of pajama time. So similar to our previous study that we discussed in residence, this is a really medical culture thing, and it's going to be hard to break. There just might not be time in the day. And one of the reasons that explains that is we actually see a pretty big increase in the amount of visits per week that a physician can perform when they have a scribe. So we've got an increase in almost 6% total visits, 7% in established patient evaluation management visits, and 5.6% in new patient evaluation management visits. So what we can see here is this is a pretty low cost of an effective intervention to increase the capacity of our physician workforce. So what we want to know also is sort of how does scribing go sort of long-term? So that's our immediate effect, but really teams are something that take a while to gel. You need to learn the preferences of each other. You need to learn sort of the workflow environment. I always say, it takes the first 6 months in a hospital system to find where the bathrooms are, much less contribute positively as sort of a new team member. And so this is what we call a very convenient event study plot. So we can look at here, we have evidence of parallel pre-trend, which means these physicians prior to the adoption of team-based documentation support or scribing look very similar. And then we can see sort of what they look like over time, where each of these dots with little whiskers here are coefficient plots of the effect estimate and the 95% confidence interval. And so we can see here actually, and this is specifically time and notes per week, the effect gets stronger the longer they have the scribe. So you can see that there is not only an immediate impact on efficiency, but as teams have a chance to sort of get to know each other, there is an increased effect over time, which is even better. So we can see sort of the stability of the team has an important impact there as well. And this is true across all of our outcomes, where we can see as teams have a chance to sort of work better together, that productivity impact, if you look at that panel D there on the bottom left, is really big. Similarly, with time and notes per week, we see a big impact on a reduction in time spent by the physician, a big increase in productivity, and really just a shocking amount of sort of low cost, high throughput interventions here. So measuring the impact of teamwork on EHR time and productivity is something that's possible at scale only using this sort of new EHR audit log metadata. It has a really powerful tool. This is extremely useful operationally and clinically as well. So you can sort of see the impact of stable teams and say, wow, I know modular scheduling for our clinical workforce might be cheaper and easier, but it turns out if you have stable teams, you get higher quality care and bigger impacts on your reductions. We can find that team support for documentation generates this sort of substantial durable savings in both EHR time, and it increases clinician capacity. So this almost certainly pencils out as extremely ROI positive if you're a health system CFO thinking about, should I invest in sort of helping my physicians with scribes? And if you're a policymaker or someone who's interested in forming policy, this is a really low cost, efficient way to improve capacity and alleviate what is really a crisis of primary care clinician shortages. So overall, I think the potential of EHR audit logs is really obvious when you look at these types of studies. It can be done at scale with an incredible amount of detail and granularity and find really actionable, useful insights for health system leaders, for physicians, and for policymakers. So it's really a potential gold mine for all sorts of use cases. Anything interested in clinical care delivery can be learned something from EHR audit log metadata. Working with the data is complex and really difficult. A lot of different forms of audit log data exist depending on how granular or how close to the rails you want to be. But I think it's definitely something worth familiarizing yourself with if you're working in a clinical care delivery organization at all, just so you have an idea of, if we want to measure this, I bet we could do it using audit log data, and then finding the person in your organization who knows how to access that. I think it's really worthwhile to be aware of how this works, how it works, and what it can tell you as you go forward in your career in medicine. You're working in healthcare in any capacity, I think it's a really useful and insightful data source. I think it'll only grow in popularity as people sort of discover how powerful it is in terms of telling us about how clinicians practice. And I think it's going to be a really fantastic thing to keep an eye on in the future. And that's all I have for today. So thank you so much. Feel free to, if you have any questions, feel free to send me an email or follow me on Twitter, where I am very active, and you'll get a nice mix of research and pictures of my dog.
Well, thank you so much, AJ. This has been just absolutely phenomenal. And congratulations to your team, Julia Adler-Milstein and the Bates et al., the Harvard crew. You all are really doing remarkable things with this. One question I might ask, so this is a healthcare innovation class typically. Where do you see new businesses coming out of this sort of data management, data exploration?
Absolutely. So I think one of the most obvious ones is more detailed measurement and then interventions and measurement of the effectiveness of those interventions for physician well-being. There are a couple of startups that I know that are doing this, but not that many. And given how much of a crisis it is, and given how much we're seeing, a focus on physician well-being, on curbing burnout, on increasing supply through maintaining our existing clinical workforce, I'm surprised that there aren't more interventions based on this. And you could do things like develop strategies or algorithms that do things like finding your outlier physicians, ones that are spending a ton of time, and look at their documentation. So I bet they're doing a whole lot of manual documentation. They're typing things in manually. They're not using sort of templated text or the various productivity tools, and then doing targeted interventions, targeted one-on-one training with them to bring up their efficiency. And so I think that sort of thing is one area we're going to see a lot of sort of activity on the business side over the next few years. I think another one is sort of based around clinical productivity and teamwork. I think right now we've moved, a lot of organizations have moved to a very modular system of scheduling where everyone is shift-based. You're getting sort of plug and played with different members of different care teams, and you might work with, MA number 1 on Tuesday, MA number 2 on Wednesday, and never really develop this cohesive bonds. I think EHR audit log data is a really great way to sort of measure and see, is this really effective? Is this really saving us money? I know it's easier. I know it's, you'd pay out less overtime, but I do think, there are increasing amount of studies that show the value of stable teams and teams who are familiar with each other. And I think up to now, it's been really hard to demonstrate this at scale because it's just really labor intensive to go in and say, okay, I'm going to measure, how effective and how, useful everybody is and how quickly our patients are getting done. At team 1 versus team 2 versus team 3. With audit log data, you can sort of prove that much easier. And really just anything that involves, clinical workflows. I think there's all sorts of questions around how much asynchronous messaging should we be doing? Should we be, sort of trying to convert these into visits? Should we be trying to just address the problem so that we can have more higher acuity visits that bill for more? With audit log data, you can see how much time you're spending on each message, how many messages you get, and sort of look over time as that changes, to truly validate your strategy of is this something that's going to work out or not? So I think, there's all sorts of questions that I think audit log data is going to be really useful for sort of on the next few years.
That's great. You alluded to in one of your slides, artificial intelligence and those sorts of things. How do you see integrating those technologies into this?
Yeah, I think AI is going to use audit log data to a pretty significant degree as it sort of gets more incorporated into clinical workflows. So for example, I know at least one company is working on triaging those asynchronous messages automatically. It's using a natural language processing algorithm, but it also needs to be able to pull things from the audit log of who is the physician who last touched this patient's chart, who is the physician who last touched this patient's messaging, because it wants to route them to the right person. So if it was an MA who did it last time, it'll route it to that MA first. Or if there's a physician who works in sort of an urgent care setting, it'll let them know that they received a message that's relevant to the last time that they were there. And so I think that's a really important way for it to draw data and learn from sort of the previous workflows of that patient and how they've flown through how they sort of move through the healthcare delivery setting so they can be properly attributed.
That's great. Well, I see we have a few people in the audience. I'll open it up to them. Do you have any questions from the class?
Hi, my name's Bailey. I have, I guess, just kind of a general question. Do we know if at UAB currently there's any kind of push towards this? For example, I know that my the PCP that I see has used a scribe the last few times that I've visited her. However, and I also work at UAB, and in my current department, this is such a pain point in my area. I work in diagnostic imaging, and my lead technologist, who's very skilled at being a technologist, is being used to essentially fix problem orders and try to contact physicians who get annoyed that they're being contacted about having to fix orders because we struggle to find what exactly it is they're looking for and what the appropriate diagnostic imaging is that they need to make sure that we code it appropriately. So I'm just curious if there's any information about UAB utilizing any of this type of data.
I know UAB is a Cerner site, and at least one of those papers, the one on sort of resident learning and experience, came from UAB data. So there certainly is the data is there, and Cerner has platforms to do it. I think their technology is maybe slightly behind where Epic's at, and there are just fewer people who are skilled with the Cerner backend platform. That said, I'm sure that they exist at UAB, and it's just a matter of finding them and getting them applied to the right problem.
Yeah,
So that's essentially, oh, I'm sorry.
No, Bailey, go ahead and reach out to me and I'll try to put you in touch with some of the folks that manage our lights on.
Okay, yeah, that would be great. I just, it seems like some doctors are, kind of get it. And then we have some that I guess it would just be maybe like a cultural change. Like you said, it would be a change over time, but it's definitely a huge pain point for us.
Yeah, I think the audit log data and the lights-on stuff is a super useful tool also for proving to system leadership something works. So you can say, well, this doctor has a scribe and they're spending way less time in this. And so maybe we should expand that to, these other areas of the health system because it's going to pencil out to be cost effective. And a lot of getting things done in a health system is proving to someone who has check signing power that something will work and save them money, which is a tall task a lot of the time.
Thank you.
That's great. Any other questions? Well, hearing none, I'll just thank you one more time. AJ, thank you so much. I really appreciate you doing this. This has been super informative. For other students who are interested in this, there is a working group that does research on this that AJ is one of the leaders of, and I'm a member of, and we'll be happy to link into that some, etc. if you're really interested in it.
Well, thank you again for having me. This is fantastic.
Well, thank you very much. I'll talk to you soon.
All right. Bye.